This is SG2 Perspectives, a conversation with industry experts and SG2 thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
We've really been pushing this concept of calling it not post-acute, but continuing care. And as we've been having this conversation, specifically thinking about hospital at home and the new care models in the home, it really makes me come back to that idea that this is really not about post-acute. It really is about continuing care.
Welcome to SG2 Perspectives. I'm your host, Trevor. This week's episode, I get to welcome two new colleagues, Jayme Zage and Katie Elia, to the show to talk about post-acute care, such a poignant topic right now, an area that was already rapidly evolving before COVID-19 and now presents some of the biggest challenges and a lot of new opportunities for our health system members. So, Katie, regulation was evolving pretty quickly in this space pre-COVID. How did all that accelerate as a response to COVID-19?
Trevor, it's first important to start with where we were prior to COVID, just to really lay the groundwork. SG2 had been closely tracking this rapidly evolving regulations in the post-acute care space as the industry really continued to design and implement payment models to align with the IMPACT Act. A huge move that occurred back in October of 2019 was the overhaul of the SNF payment system, also known as the patient-driven payment model, or also referred to as the PDPM. On top of that, just a few months later, the patient-driven groupings model, or the PDGM, came into effect for home health. At a high level, these models really operate with the goal of more closely tying payment to patient characteristics. And that is making sure that most resources go to the most complex, highly acute patients. They designed these models and they implemented these models just shortly before COVID to incentivize these post-acute care sites to take into account all of the considerations around the patient rather than the specific volume or site of services delivered. These models had the goal of not only lowering costs, but also improving outcomes and advancing that movement towards this post-acute care site-neutral payment system that we've been talking about for a few years now. Really think about that idea and that these models really hinge on the idea that right patient, right time, right place. But interestingly enough, we actually saw that these payment principles or goals, if you will, did not really become any less important in the wake of COVID. The question of appropriate site placement and utilization was actually put into question more so than ever before. And systems not only began to leverage those CMS waivers to creatively and appropriately utilize post-acute care beds and space, but they also used post-acute care spaces to enable more rapid transfers and transitions and to control infection. We saw that not only did this happen, but also those existing partnerships that we've been suggesting and recommending to our clients to build over the years, those preferred provider networks. That really provided that foundation for systems and post-acute care facilities to work together amid the crisis to adapt their protocols and determine the best roles for those individual sites. So again, really looking into post-acute care sites, the different services that they offer, and the most appropriate placement and safe placement for patients. But I also think it's important to note that we also continue to see this increased deployment of virtual health capabilities to not only mitigate exposure for patients and workforce in the community, but also to really leverage and extend the power of the post-acute care workforce, which I think it is another topic that would be important to address. But much of this is really due to the fact that these regulatory barriers continue to drop. The latest development came out just 2 weeks ago with CMS proposing permanent changes to home health, the payment mechanism, to allow for home health agencies to utilize telemedicine as an allowable administrative cost. This is a really huge step. This is a step in the right direction for the industry. We know that the use of remote patient monitoring, whether that be through the distribution of home monitoring kits, which we've seen a few organizations do, such as Atrium or Providence St. Joe, or the movement of non-critical acute care patients to the home. Telemedicine has a huge role to play in driving efficiencies, lowering costs, and extending the resources in the post-acute care space, which we know is so critically needed at this point. And so finally, we're starting to see reimbursement align with those goals. And more importantly, we're starting to see this as a growing competencies that health systems have the opportunity to an incentive to pursue if they haven't already. So with all that said, pre-COVID PAC regulatory space was moving pretty fast and was evolving quickly, but now we see those shifts that we expected only accelerated as the payment constructs continue to drive that downshift in post-acute care volumes to lower cost sites of care. We have seen and only continue to expect COVID-19 to accelerate this shift we saw.
This is Jayme. I would add to that there were a number of regulations that were also relaxed in addition to the payment components. And for COVID, it was all about improving the ability to provide safe care to patients. But the restrictions on who can be cared for in the home, for instance, were relaxed significantly. So some individual patients who might have been excluded from home health services in the past were now allowed to be managed in the home environment as a way to help maintain that safety. Similarly, with the skilled nursing, opening up and easing those transfers, as Katie suggested, is one of those things that CMS put in place to help move patients through different sites of care, again, to try to mitigate some of the challenges that were happening, in particular in the Northeast and in New York State and others that were dealing with the really high initial spike in volumes and just having a need for beds. Being able to move patients around more effectively so that we could better treat the population as a whole, as well as improve safety, is really what drove a lot of those regulatory changes in response to COVID. And those accelerated that right patient, right place, right care setting concept that the original regulations were really aiming to do.
All right, so Jayme, you live in Southern California. Put yourself in the shoes of one of the local health systems. You're a post-acute care leader. How would this acceleration of regulatory changes open up new opportunities for you? What would you be exploring?
I would certainly be exploring what's going on with home health services, looking at alternative waivers, who else I might over the long term be able to continue to manage in the home market, and what technologies and other care redesign approaches I need to be able to meet that need. The number of patients that we're looking at in the future to be cared for in the home is really going to be a huge opportunity. And we're not going to be able to do it in the same way that we've done it before. So that's where I would be focusing my long-term strategic efforts. In the short term, though, and realizing that skilled nursing is something that is going to, even with this downshift, skilled nursing is something that's going to be and continue to have some relevance and importance. We need to support those skilled nursing facilities in this time as well. And so I'd be looking at how we support them more effectively through this critical period.
Yeah, say more about that. Is this the end of the nursing home model as we know it? What does their future look like?
So the nursing homes, they've been really hard hit by the COVID impact. And we've seen a lot of outbreaks of infections in both skilled nursing and in more long-term care nursing homes. They have become a place where we're concerned about virus transmission. And we're expecting that the volumes are going to be down pretty significantly through 2020 and 2021. And honestly, it's probably going to be close to the end of the decade before they start to come back to where they are today. But we think that they're still going to have relevance. And really what it's done is accelerating that shift away from skilled nursing to home health services, to other sites of care that don't require that inpatient skilled nursing stay. But I do think it means we're going to need to take a look at that long-term business model around skilled nursing facilities as we address this. They've been hard hit. It's been a challenge, but there's still going to be a place for them in the future.
Wow, volumes don't bounce back until the end of the decade. That's incredible. But those patients are still being cared for somewhere. It's probably the home. So what's the future of home health? Give us kind of the rundown of what's really encompassed in home health and how is that going to just be an increasingly relevant and effective post-acute care site?
I think it's important for us to establish that, the term home care broadly describes an array of wellness and monitoring and personal care services, right? But the term home health specifically refers to the use of skilled services for homebound patients. And so what we're going to see in home health is really an expansion of this definition. We mentioned earlier care delivery advances, evolving financial incentives fueled by COVID will only increase the acuity of the patients managed in the home environment. And we expect to see this type of service mix in the home to increasingly include this high acuity care, such as chemo infusions, dialysis, and even wound care. Not only that, but this type of care also allows for chronic patients to be treated in the home with oversight from their own primary care physician who is getting reimbursed. So there's also an opportunity here in the home health area to not only align economic incentives, but also to extend the physician practice across the continuum. We also see that leading health systems have also begun to optimize home health, not only to treat high acuity patients, but to use these innovative remote monitoring technologies to expand care for all stages. And that can include anything from preventive risk assessments to long-term care. It's important to note that this pre-COVID data did show that 2/3 of home health episodes are not preceded by a hospital or other post-acute care stay, which shockingly, I don't think we talk about enough. It means most patients are bypassing an inpatient or post-acute care stay altogether. And some low acuity care patients are even being directly admitted to home health from the ED. We're starting to see this even more, especially with COVID, to ease up that hospital capacity. Organizations should work to broaden their reach, to prepare for growth in patients, not only discharged directly from the hospital or a skilled nursing facility, but also increasing the amount of those direct community referrals, given the fact that home health has really expanded its definition.
So, focusing a little bit more on one specific model, is COVID going to be the nudge to get us to more advanced models like hospital at home to really take off?
I think so. There's a number of things going on. And, we talked about the regulatory components with the virtual pieces, right? And there's, as Katie mentioned, there's movement in Congress and in CMS to make some of the payment changes for remote patient monitoring available and permanent. And then you add into the fact that we want to keep some of these most chronic patients safe, keeping them out of the hospitals where they're most likely to get infected, those types of things. We are seeing a huge spike in interest in terms of hospital at home or care at home type models. We've heard everything from hospital at home, which we've been talking about for years, but sniff at home, observation at home, right? It's what type of care can we move to the home? So we've started to refer to it as care in the home. And it's really thinking differently about who needs to be present with the patient, who needs to be part of the patient's care continuum, where it's delivered, how we deliver it. And the technology side of that is really an enabler. And the regulatory and payment piece really comes into play in terms of supporting that shift. And that's something that has really, I think, been holding it back over the long term, even as we've seen more and more clinical evidence supporting that this has some downstream implications for reducing readmission rates, unnecessary admissions, those types of things. That regulatory payment piece is really, I think, that nudge, along with the fact that the technology's there now that we can really do this with a pretty significant patient population.
And Jayme, I think it's also important to note that we know that upwards of 90% of seniors prefer to stay in their homes as they age. That's really no surprise. But in general, especially, amid the COVID pandemic, consumers are reluctant to seek in-person care for the foreseeable future. So there's also a consumer push here. We definitely understand that there's certainly a large part of the population that will still require some level of institutional care. We still expect that home health to really take off as the post-acute care site of choice for more and more patients and families in the future. And so key takeaway, home health really will represent a significantly larger proportion of that total post-acute care volume than it has historically. And it's so critical right now to have those strategic partnerships in place to bridge those gaps, to smooth transitions, and to really have an efficient model in place to support higher acuity patients.
Absolutely. And even for those patients who might go to a SNF for a period of time, may need some ongoing home services as well. So I think that home health piece is going to be important there. And I think we need to think about hospital at home as well, it's not necessarily a home health correlative or model. It's a little bit different, right? It could be a short-term period, like an observation type period, 2 to 3 days. And it's thinking about it as an alternative to an inpatient stay, as opposed to a 30-day, 60-day episode of care. It's a little bit different from that perspective when we're talking about the more acute conditions. And it enables us to think differently about how we use the workforce and the technology to support that type of environment.
Yeah, you guys make a strong case, but I get to throw water on the fire now. Who's going to provide this care? I mean, so many opportunities that we look at across the healthcare spectrum. We have a workforce supply challenge to make that opportunity real. This seems like a case where there's a huge shift and it's going to correspond to a workforce shift. So why might workforce challenges make new opportunities, particularly home-based care opportunities, challenging to pursue?
We've been struggling as a nation with the home health nursing workforce for years, right? And it really has been a concern and a limiting factor in many markets in terms of the forecast. So when we think about our forecast being close to 20% growth in just home nursing visits over the next 10 years, that workforce piece is part of that challenge because of some of the regulatory changes, moving from the 60-day to the 30-day episode, the ability to now use telehealth in the home and do telenursing visits, enabling us to do things in a different way. And so it's important to look at it from how we deliver care currently in the home environment with home nursing, which is the nurse drives around from patient to patient, and they may see 4 to 5 patients a day if they're not having to do sort of a new intake or education. And so that's pretty limiting. They might have a pretty limited scope of clientele that they're working with over time. But if you can start to think differently about what that care model looks like, who's actually in the home with the patient, maybe it's a nursing aide. Also, you've got physical therapy that could be coming in. Maybe the patient has a caregiver that can support the nurse doing more of a telehealth visit. And there may be others who could do some of those visits as well, who support the patient's overall care continuum, care recovery. So I think we've got to think differently about what that care model looks like. And I think we've got to think about how we use technology to support extending those nurses that we have. I think we've also got to think about redeployment. If we're moving patients out of skilled nursing, if we're moving patients out of the inpatient care setting, are there workforce elements in those settings that could be redeployed to the home health environment?
Yes, Jayme, great point. It really is about the creative use of staff and technology. We've seen some of our clients amid the pandemic really prioritizing their support of post-acute care assets, knowing the struggles that exist. And so they're supporting with medical management, staff education, and this can include PPE and infection control, but also additional workforce resource support management. Lots of opportunities to extend our workforce, whether it be through staff in the hospital, across the campus, or through technology. We also are seeing that because of the COVID pandemic, some organizations have actually just started to invest in new virtual health solutions that has been driven with the focus and spurred by treating patients in skilled nursing facilities and having buy-in from the nursing home staff to move towards these types of models. And they said without that buy-in from the staff, it was really tough and a challenge to move forward with some of these new solutions. So having buy-in and being able to have the staff serve as not only a driver, but almost a proponent of these solutions and new care models, that really helps this situation.
Trevor, as I'm listening to Katie, I'm reminded that over the past 3 to 5 years, we've really been pushing this concept of calling it not post-acute, but continuing care. And as we've been having this conversation, specifically thinking about hospital at home and the new care models in the home, it really makes me come back to that idea that this is really not about post-acute. It really is about continuing care. And how do we get the right resources to the patient where they are. And so while we talked and started at the beginning of this, thinking about the right patient in the right care setting, maybe it's the right services that meet the patient where they are. And that's what we would like to think about as we talk about continuing care moving forward in the future.
That's a great closing thought. And, just thinking anecdotally about opportunities for virtual here, having someone come into your home, I'm thinking about my grandparents having a caregiver come into their home. It was so invasive, and their personal relationship with that person made the switching cost very high. It made it hard to think about changes. But virtually, the switching cost is so much lower, and it's so much less invasive that relationship is, while still important, it's not the same level. And so it just seems like such a more flexible model. So I'm really hopeful that there's going to be, like you said, Katie, some really creative options there. Well, thank you both today. You covered a lot of ground really quickly. Thanks for listening, and please subscribe or follow if you want to hear more. I also want to recommend another Vizient podcast, The Modern Practice. It's on Vizient's Medical Leadership channel and provides a clinical perspective into current issues affecting healthcare today. Thanks, everyone. Have a great day. Stay safe. This has been another great episode of SG2 Perspectives, where industry experts and SG2 thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. Contact us anytime by sending an email to sg2perspectives@sg2.com. We'd love to hear from you. SG2 revolutionized healthcare demand forecasting with the Impact of Change forecast, and today we're the industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks so much for listening, and we'll see you again soon.